Hello, everybody. I'm delighted today to have an extra vlog class this month and to welcome Dr. Patrick Harrington, who's a consultant haematologist at Guy's Hospital in London. And the topic today is the COVID vaccinations. And I'm going to start by asking you, Dr. Harrington, about the research you did for COVID vaccinations and the impact for MPN patients.
Thank you. Thanks, Nona. Yep. So I was about halfway through my PhD when the COVID pandemic began. And so my research plans were affected significantly by that. Any non-essential research was halted, obviously. But I was then well placed to set up different research assays and laboratory assays to investigate COVID. And it was obviously, being a new condition, it was a rich area of interest, and lots of research needed to be done, as we all can recognize. So what we did in our laboratory, the first analysis we did, and as many of you will know, Guy's and St Thomas's has a large population of patients with myeloproliferative neoplasms. So we were able to collect samples, and this is fairly early on in the pandemic. We were able to collect samples from patients who'd had COVID. And the first thing we did was assess whether we could assess T-cell immunity in this patient group. So we did this by taking the patient's T-cells, and this is including in patients up to 6 months after infection, and incubating the T-cells with different peptides from SARS-CoV-2 and seeing if we could invoke a reaction. And what we were able to demonstrate was that these patients with MPN were able to have a fairly robust T-cell response over 6 months post-COVID infection in some cases. So it was one of the first descriptions of T-cell immunity in patients who were perhaps considered to be immune suppressed. And it showed the durability of the T-cell response. So that was the first area of the research that we did in my laboratory. The second thing we did was, and the large focus for the rest of the research in this area, was looking at the response to vaccination in MPN patients. So firstly, we looked at a response to vaccination in a relatively small group of around 20 patients with MPN. And this was one of the first reports to be published internationally on this. And what we found was really encouraging, in that around 80 to 90% of patients had both an antibody and a T-cell response after a single dose of vaccine. So that was really reassuring at the time. We then went on to do further analyses after 2 doses of vaccine and after 3 doses. And again, generally speaking, we saw very positive results in terms of the response to vaccination. We did identify some groups who did have an inferior response compared to others, particularly those patients taking the JAK inhibitor ruxolitinib were noted to have both a weaker T-cell response after 3 doses of vaccine, but we also saw that after 2 doses of vaccine, around half of the patients in our cohort on ruxolitinib had either a negative or borderline response. So that was really interesting, and what it enabled us to do was to really focus on this patient group who we recognized to be immune suppressed generally because of the effects of ruxolitinib, and it allowed us to really focus on alternative strategies and make sure that these patients were prioritized for antiviral treatments and other options. So I think that was useful finding.
Sounds very, very interesting. Just a question here: are MPN patients immune suppressed, and which patients are more at risk?
Yeah, so that's a really interesting question, and there have been some large studies that have specifically addressed this. So there was a large Scandinavian population-based study that looked at incidence of infection across MPN patients and compared the rates of infection with that observed in the general population. And what they found was that patients with MPN were noted to have an increased incidence of both bacterial and viral infections when compared with the general population. So based on that, we would have to recognize that patients with MPN could be considered to be immune suppressed, but I think it's quite variable, and the MPN patient group is extremely what we call heterogeneous, in that patients are very different. So some patients will be considerably more immune suppressed than others. And what we know is that conditions such as myelofibrosis associated with a great degree of inflammation, and alongside that comes a degree of immune suppression. So patients with myelofibrosis are recognised to be immune suppressed, and those, particularly those with more advanced disease, would likewise be recognised as being immune suppressed. The other aspect we have to focus on is the treatments that people are receiving. So we know that both the disease and the treatments that people are receiving can both contribute to the immune suppression that is observed. And as mentioned in just now, the treatment is particularly relevant with regards to immune suppression that is quite common in the myelofibrosis patient group is ruxolitinib. And similarly, other JAK inhibitors that affect JAK-STAT signaling pathways plays a central role in normal immune cell function. So for T cells and B cells, which produce antibodies, and other types of immune cell populations, such as NK cells and natural killer cells, which play a central role in antiviral immunity. And there has been another study that's looked specifically at that question and within the MPN population, and it was exactly that finding that was observed, that patients with myelofibrosis, and specifically those taking ruxolitinib, were the MPN patient group who had the highest incidence of infection across a group of around 1,000 MPN patients. But we do know that we do also recognise that a lot of patients with MPN will not be significantly immune suppressed. So, for example, patients who are just on active surveillance, not receiving any treatment, would likely have fairly functional immune systems.
Again, that's really, really interesting. I think the other question is the NHS here in the United Kingdom have sent out invitations to people to go and have another vaccine. Now, does the timing of the vaccine matter if you've had one within the last 6 months?
Yeah, so the current advice with regards to that is that patients should have there should have been a period of at least 3 months elapsed since your last vaccine. So that's the current guidance in that area. So if you've had a vaccine within 3 months, then you'll need to wait until that time has elapsed before you're going for your booster.
Now, we hear on the news and read in the newspapers about this new mutation. And does the current vaccine cover the new variant mutations?
Yeah, so it's a good question, and as with all of these vaccination programs, similar to the program that's offered for flu, the health services have to try and predict which variant is going to be dominant at any one time, and that's not always possible to do. So the current variant that's emerged, which is the BA.2.86, or also known as the Parola variant, which seems to be the new variant that's emerging, is highly mutated. So in some respects, it's similar to the Omicron variant that we saw. And the concern was that because of the significant number of mutations, it may evade current vaccinations. What we've seen from the data that's being published by the companies involved in making these vaccines, so that's from the Moderna, Pfizer, and Sanofi, are the current vaccines that are being offered, and each of these companies have published some data to suggest that their vaccine does offer some cross immunity against the current variants. We know from our own research that looking at Omicron, that the vaccine that we saw issued did actually neutralize the Omicron variant quite effectively. And what we saw was that after 3 doses of vaccine, so this is the vaccine that was initially targeted against the Wuhan original spike, so it wasn't targeted against Omicron, but we saw a good degree of cross immunity, and that the response against the Omicron variant was significantly better after 3 doses compared with that observed after 2 doses of vaccine. So what we can see is there probably is a cumulative effect, and that these vaccines, whilst they're not necessarily designed against this particular variant, do offer some cross immunity.
Again, very helpful. And the new variant, I mean, is that sort of circulating widely in the population now, or?
It's very early to say, and the problem we have in that respect is that as I'm sure you're aware, the testing is significantly limited compared to the testing that was being done previously when the pandemic was at its height. So it's very difficult to say how much the current variant is circulating, and there is some data from things like the Zoe app and from data in healthcare workers who are being tested to say that their rates are increasing, but I don't think it's extremely prevalent. What the important thing is what we are observing within hospitals, and are we seeing significant rates of hospitalization? Because the key to the vaccine efficacy is maybe not so much that it prevents infection, but it prevents severe infection. So it prevents patients becoming significantly unwell, requiring hospitalization, requiring oxygen treatment. And we're not really seeing a significant increase in that respect at this stage. Although there has been a slight increase in hospital admissions for COVID, it hasn't been that significant thus far, but it's something that we need to continue to observe very closely. And obviously we would advise patients who are eligible to get the vaccine to do so as soon as possible, because the current vaccine that is being offered has been altered slightly compared to the previous vaccines, and thus is recognised to result in a slightly higher antibody response against different strains of Omicron. So that, just to reiterate, patients who are over 65 and those who are considered clinically vulnerable, or family members of those who are clinically vulnerable, are eligible for the vaccine, and we'd encourage patients to seek that.
And just that's another interesting question, because does it matter if you switch vaccines? What's the, sometimes you can get one vaccine and then the next booster will be another. What's the impact of that?
Yeah. That's an interesting question, and it was something that was being evaluated in some large studies in the general healthy population earlier on in the height of the pandemic, and there was some data to suggest that switching vaccines may actually result in a more robust immune response due to slight differences between the vaccines. I don't think that we have good evidence to support that at this stage with regards to new variants and the current vaccines that are being offered. So what I would suggest is that patients should just take the vaccine that is offered to them, and I wouldn't necessarily suggest that patients seek out different vaccines to ones that they've had previously, although there was some data to perhaps support that earlier on in the pandemic.
This has been incredibly useful, and I'm sure that I can't thank you enough, actually, because I know that there are lots of questions around, do we have a booster, do we not have a booster? And I think what you've been able to illustrate is actually for MPN patients, it's really important that we do have boosters. And I'm sure there will be some patients who are on ruxolitinib who will be a little bit concerned, but I guess the answer is they need to talk to their own haematologist and clinical nurse specialists about that. Is that right?
Yeah, I would agree, but I would suggest that whilst the data for a response to vaccination in patients on ruxolitinib was not as good, that doesn't mean we wouldn't suggest patients get the vaccine. It's certainly still advisable that they should seek out the vaccine and get it, and the chances are they will still have a response. When we did see that after 3 doses, if anything, it's more important that they get the vaccine booster because their immune response may not be quite as good as other patients.
Well, I can't, as I said just now, thank you so much. And I'm sure that the MPN community will be really interested in this because it's a very current topic. And as the winter progresses, and you've given us some very helpful information. Thank you for sharing this conversation with me.
No problem. My pleasure.